Yes.
Okay, great. Okay.
Yeah.
All right, everybody. Thank you so much for joining us again, and welcome to the Arthur Rotenberg Suicide and Depression Studies Program Public Lecture Series. I'm Sakina Rizvi. I'm the chair of this program here at the University of Toronto at St. Michael's Hospital. And for those of you joining us for the first time, essentially our goal here is really just to share knowledge with the public as much as we can. And there's incredible research going on around the world, and just wanting to share that. So if there are things you want to know about, please do share that feedback in the link that will be in the chat. We are going to be here monthly until June on Mondays from 12 to 1. So you can set up for the updates as well. I also ask that you use the Q&A function as well at the bottom of the Zoom. I'll be monitoring that at the end for any questions you have for Dr. Dunlop. And also, we just want to be mindful that we're having these conversations with emotional safety. So, we are still talking about suicide risk, and while these talks are meant to inspire, we still need to be mindful of the fact there are things that can come up that can be activating. So just please be mindful of that. Take care of yourself, support yourself as you need to. These sessions are recorded. They'll be available on YouTube. So if you need to step away, just make sure that you're taking care of yourself. And feel free to let us also know where you're coming from. And it's such a pleasure for me to introduce Dr. Katie Dunlop. She's a staff scientist here at the ASR. She's at the Keenan Research Center for Biomedical Science and the Center for Depression and Suicide Studies at St. Michael's Hospital. She's an assistant professor in the Department of Psychiatry at the University of Toronto. And her research focuses on how biological factors affect symptoms and treatment response in mood and anxiety disorders. She studies treatments for depression, including medications and brain stimulation techniques like repetitive transcranial magnetic stimulation. And currently, Katie's work combines brain imaging, biological data, and clinical information to better understand how the brain relates to behavior. So the goal there is to use that information to help choose the most effective treatments for people with depression and high suicide risk. So she's going to talk to us today about the neurobiology of suicidal behavior. And welcome, Katie. Oh, you're on mute.
There we go.
Yeah. Yeah.
Thank you so much, Sakina, for the kind introduction. Today I'm going to be talking about the biology of suicidality in the context of subtyping. So it should come as no surprise that suicidality and suicide is a huge problem here in Canada, but also globally. Every day in Canada, 13 people die by suicide, which totals approximately 4,700 deaths annually. And things aren't getting better. The prevalence of suicidal thoughts increased over the course of the pandemic by about 55%. And we also saw an increase of deaths by suicide by 10.5% in recent years. Unfortunately, we're not moving the needle in terms of academic research and clinical translation. On the left here, you just see the number of publications by year across time. And we see this huge explosion in the 20th and 21st century of publications trying to understand and parse through suicidal thoughts and behaviors. And yet, even in recent years, deaths by suicide per capita in Canada have not meaningfully changed. Why might this be? Well, the reason might be heterogeneity. And what that just means is that suicidal thoughts and behaviors come from many sources. They're multifactorial. They have multiple factors that contribute to risk and resilience. They're dynamic, which means that they change over the course of time. So I open this to the group. Feel free to put it in the chat or in the Q&A. But what might be some sources of heterogeneity or variability to consider when we think of suicidality or suicidal thoughts and behaviors? And I'll keep my eye on the chat. Anybody? Yeah, drug use, financial position, trauma, absolutely. Yeah, those are some great examples of things that may or may not be present that could be contributing to suicide risk. Systematic oppression, absolutely. Culture. Yeah, all of those things I agree completely, definitely contribute to risk and resilience for suicidal thoughts and behaviors. So a common theme in a lot of these, it seems like, is environmental or situational heterogeneity. And these could be things like the physical space in which we live, like our neighborhoods, climate change or natural disasters, socioeconomic factors, social factors, home environment, parenting and family structure, access to lethal means or not. Um, could be things like the digital environment as well, cyberbullying, fear of missing out, impact on sleep, or other things. But there are actually other sources of heterogeneity, not just environmental or situational heterogeneity, but also clinical heterogeneity, which I see Aisha has mentioned mental health disorders. But even within the same diagnosis, say of depression, two people may be diagnosed with the same disorder but have different constellations of clinical symptoms. So one example here of two different patients, both of whom are feeling sad and having thoughts of suicide, but participant or patient number one is also experiencing a lack of sleep, lack of appetite, as well as anger and irritability. Whereas our patient is also feeling sad and having thoughts of suicide, but they're feeling also excessively guilty, fatigue or lack of energy instead of insomnia, and poor concentration, poor memory, and difficulties in decision making. Both of these two individuals would potentially be diagnosed with major depressive episode, and yet the different constellations of symptoms contributing to their disorder are very different. Another source of heterogeneity can be cognitive heterogeneity. So, numerous studies over the last 30 years or so have looked at different cognitive characteristics, both traits and state-like factors. So, moods, cognition in the moment, but also personality factors that could be contributing to suicide risk. Previously, two personality traits in particular have been associated with increased risk, such as neuroticism and extroversion, but also aspects of cognition, hopelessness, impulsivity, cognitive flexibility, which is the ability to change tasks from easily from one thing to the next. More recently, we've been trying, or we, but the National Institutes of Health in the United States came up with something called the research domain criteria, which are domains of cognition and behavior. And recent research has identified that one system in particular, the negative valence system, which looks at cognitive processing of negative stimuli or avoidance behaviors, so avoiding negative stimuli or punishment, is also implicated in suicide risk. But there's also heterogeneity in biology. So this could be in a number of different domains. It could be in the genetics. So what genes are contributing to suicidal behavior or suicidal ideation, which you can see here from this recent review. So there are sex-specific genes that contribute to suicidal behavior, but also others. Epigenetic modifications, which contribute to how genes are expressed across time. There are differences in population level genetic studies. There are brain changes as well, of course, differences in areas of the brain like the frontal and prefrontal cortex, limbic areas like the amygdala and the hippocampus, and differences in brain structure and brain function during tasks. We also see molecular pathways disrupted in suicidal thoughts and behavior with a particular role of inflammation. Oops. So increased pro-inflammation related to suicidal thoughts and behaviors, as well as altered pathways related to neurotransmission, which are the chemical ways in which neurons talk to each other. Lastly, there's also temporal heterogeneity, or when things happen. When things happen may matter as well. So when we're exposed to trauma, perhaps in childhood or early development. There's also puberty and age cognition changes, and our resilience to certain factors may change as a function of age. And then also symptoms change as well. Some individuals experience suicidal thoughts consistently and persistently, where others are more brief and sporadic. Um, so all of these different factors may be contributing to why our research has not yet meaningfully yielded changes in suicide rates over the last many decades. And that's where my research comes in, is I'm interested in leveraging these different factors to try and understand subgroups of individuals called subtypes that might yield more meaningful information that clinicians and psychologists and psychiatrists can use to inform their care. So why subtype? So if we have a heterogeneous population, like individuals experiencing through suicidal thoughts, we could look at a particular risk factor or biological marker and see no difference. Um, Subtyping allows us to find these subgroups of common traits amongst those experiencing suicidal thoughts and behaviors in order to tease apart these true differences against those who are not experiencing suicidal thoughts and behaviors. Now, now that I've sort of explained some of the sources of heterogeneity and why we might want to be able to subtype these people, has this been done yet? This notion isn't new. In fact, the I guess, grandfather of sociology, Emil Durkheim, in 1897 published a book on his observations of suicide. And he observed four different suicide subtypes. And of course, this is over 100 years ago now, and these are somewhat antiquated. But he outlined in his book that there were four different subtypes of suicide based on different atypical or poor integration with social systems or what he called moral systems related to things like financial instability and engagement with society more broadly. And of course, these aren't have not meaningfully changed sort of the way in which we subtype individuals now. But I believe that it is worth noting that this is something that has been thought about now for over 100 years. And while Durkheim's subtypes were based purely on his own observations, we now have more sophisticated and data-driven techniques that may allow us to find novel subgroups of individuals. So how do we now tackle this? There are sort of two different schools of thought when we think about, defining subgroups of individuals. The first is top-down, or what we would call symptom-based, which is where we look at people with common, clinical symptoms or perhaps environmental symptom characteristics, and try to use that information to find groups of individuals that then differ on underlying biology. And then the other way we could think about this is from a bottom-up based approach, where instead of focusing exclusively on symptoms, we focus on what is commonly different in the brain or in underlying biology that might yield us subgroups, meaningful subgroups for clinicians to use. I would also argue in the suicide world, there is a third group of individuals, or a third way of tackling heterogeneity, which is leveraging theories of suicidal thoughts and behaviors and how they lead to attempts. And one of the, I would guess, most studied subgroup models in suicide is this theoretical model, which leverages underlying theories of suicide related to not just mood or clinical symptoms, but also entrapment and how different clinical or environmental situations yield to feelings of entrapment and hopelessness that can contribute to a suicide risk. So in this model, they leveraged underlying theory as well as a co-creation with people with lived experience, peer supporters, psychiatrists, psychologists, and other clinicians like mental health nurses to generate these four subgroups of suicidality. And I'll just quickly walk through them. But again, it's sort of a balance between difficulties in the environment and clinical symptoms that contribute to each of these four subgroups. The first is a primary depressive cognition subgroup, which is, related to depressive features and difficulties coping with stress. And they posited that or hypothesized that this type of subgroup has a longer duration of illness. So it's a long course of feeling suicidal that ends up leading to an attempt. Perceptual disintegration is more related to psychosis and difficulties understanding or perceiving the environment, and might be very brief in duration. The last two are more related to societal impacts. Psychosocial turmoil, how they described it in the publication, is a severe blow to ego. So there's severe guilt or shame from, a serious loss, so maybe financial difficulties. It could be very reactive to changes in the environment. And then there's a desire to be released from acute emotional pain, and there may be impulsivity. The last one is inadequate coping, which is where suicidal thoughts come from the context of communicating intense distress or emotional pain, but a difficulty, communicating those things to receive help. Suicidal thoughts and behaviors in this subgroup, according to the researchers, can be seen as externalizing behaviors, which causes emotional pain. So this would be also chronic, related to personality disorder symptoms. So again, a feeling of wanting to escape, but there's a lashing out as well, given that it's seen as, from the clinician's point of view, as an externalizing behavior. And with these four subgroups, based on co-creation, they developed an evaluation skill for assessors to use. And unfortunately, as we'll show, this might not be sufficient to even diagnose individuals, because there are some clear-cut cases and some that are, there was less consensus on in practice when they evaluated the utility as well as the ease in which assessors could put people into these four buckets. So here's one example from this particular model. So this was a case that they published when they evaluated this particular clinical scale. So this is case number one. It was a suicide risk assessment of a 45 to 49-year-old married mother with three children who presented to her GP because she was concerned about not being able to resist long-standing suicidal ideation. Suicidal thoughts have been present for approximately 3 weeks, and she was not aware of any triggers. We saw a restless, anxious woman who could not make a reliable safety plan. As a differential diagnosis, we considered an anxiety disorder or a depressive illness with a secondary anxiety. And so, if we were to, based on what I told you of the four subgroups, this is this depressive subgroup. And indeed, when different evaluators assessed this woman with their scale, they indeed found that everybody was consistent with their assessment with this person. But that wasn't the case with this other person, for example, case number two. So in this is individual, there was an assessment of suicide risk at the A&E department of a 45 to 49-year-old man with no previous psychiatric history. The patient was found by his girlfriend at home after a suicide attempt by ingesting medication and putting a plastic bag over his head after writing farewell letters. He was transported by ambulance to A&E. There have been several experiences of loss, and his daughter attempted suicide by jumping out of the window of the family home, later stating she did not regret the attempt. The patient appears to be suffering from a low mood and is preoccupied with his financial decision. The patient believes nothing will ever be right again, and he is the culprit of all misery. He perceives himself to be rotten to the core, hence his daughter not being able to do anything but die. He is persistent in his wish to die, and a diagnosis of severe depression with psychotic symptoms is considered. And so is this, your core depressive suicide subtype? Is this one with psychosis features, or is this one with, severe disengagement with and severe sudden loss with respect to financial situation? And indeed, when the assessors independently used their model in this case, there was no consensus reached, indicating, of course, that more work needed to be done, revisions made to their model. Now, what about other kinds of subtypes in suicide research? Numerous efforts have been made to use clinical information to define subgroups of patients experience or people experiencing suicidal thoughts. And this has been done in the past using different kinds of data. Different researchers have used different data, and this has included things like hospital records, information collected from Veterans Affairs, clinical questionnaires, as well as in the case of people who have died by suicide, coroner's inquest papers. And a common technique that we see across all of these different subtyping efforts is a common statistical technique to define subgroups of individuals called latent class analysis. And what that just means is we take a heterogeneous population, like those experiencing suicidal thoughts and behaviors, and latent class analysis is going to identify what we would call latent classes, which is basically those subgroups, but your subgroupiness can't really be directly measured. And so that's why we would call it a latent measure. And these indicator measures, which are the data that go into the latent class model, are the things that we can observe in the data. So latent class 1, for example, here is one example of individuals that have high on indicator A, which, for example, in this case could be shopping habits. So indicator A are people who shop a lot at Best Buy. Indicator B are people who shop a lot at, I don't know, Loblaws, and C is Shoppers Drug Mart or something. And although we can't, measure their shopping habits, like subgroup membership directly, we can track, how much they shop at different stores. So the shopping history of an individual would be their indicator variable, and then the subgroups of actual purchasing preference subgroups are those latent classes. And I'll show you one example of this done in practice. I won't be exhaustive here. But this is one example done a number of years ago that used clinical information from over 1,000, nearly 2,000 healthy adults. And they collected information on suicidal thoughts and behaviors from these samples, as well as symptoms like depression, hopelessness, and others. And what they ended up finding were 3 classes of people experiencing suicidal thoughts and behaviors. Class 1, which is this one in the bottom here, had some experiences of suicidal ideation, but did not endorse having a suicide plan, endorsing any suicide gestures or attempts, and no non-suicidal thoughts, or non-suicidal self-injury, excuse me. Class 2, on the other hand, was experiencing quite high levels. The probability was over 0.7, so 70% of this subgroup was experiencing suicidal ideation. But they were relatively low in terms of suicidal behaviors, and they quite frequently endorsed NSSI. The last group was the group that was experiencing the greatest rates of suicidal behaviors, including as well as having a suicide plan. So with these 3 subgroups of individuals, they were also able to look at, different risk factors, clinical and cognitive risk factors that contributed to each of these 3 groups. And I think it's worth exploring basically the differences between the two groups that had the highest levels of ideation that differed on NSSI and suicidal behavior, such that these two groups exhibited different levels of entrapment. The suicidal behavior class reported lower levels of entrapment, feelings of burdensomeness, feelings about death, or fearlessness about death, excuse me, exposure to, oh, and they also had a higher exposure to attempted suicide or self-injury of family members and close friends. So this is just to highlight that latent class analysis is one way of looking at how different factors could contribute to non-suicidal self-injury as opposed to suicidal behavior or generating a suicide plan. Another example is with the electronic health record. So this example is looking at suicide deaths by suicide. They didn't use latent class analysis, but rather a more complicated um, uh, uh, algorithm to cluster individuals into subgroups, which I won't go into. And they looked at how these different groups differed, not just on mental health characteristics or medical characteristics, but also their medical health usage in the system leading up to their attempt, which is, I think, really interesting. And in this example, or in this case, they leveraged 800, a little over 800 deaths by suicide, as well as 4,000 individuals who died by accident. These four subgroups were defined using the suicidal deaths groups exclusively. And what's really interesting is subgroup number one experienced they were not only just the oldest, but also had the highest levels of medical comorbidities. So things like cancer, myocardial infarction, and chronic pain and cancer. They also used a lot of outpatient services prior to their death. But also they looked at, which is really cool, or really important, I think, how they paid for their healthcare services. And in this case, the majority of them used self-pay. So there could be financial distress in this subgroup of individuals. Um, Subtypes 2 and 3 here were both subgroups of individuals who had experienced mental health problems, including depression, but also anxiety, ADHD, and PTSD, with the biggest differences between these two being like the social circumstances prior to their death, with subgroup 2 experiencing employment issues, as well as stressful conditions relative to this third group. This last group, which actually was the largest subgroup of individuals, 32% of the sample, they knew nothing about. This was the largest group, but also the lowest level of medical engagement. So they didn't go to the inpatient services. They weren't seeing an outpatient doctor. We didn't know any, or the researchers using electronic health records did not know a whole lot about this group of individuals. Um, Other than that they lived in non-urban or rural areas. And so I think what's really important to note about this sample or the conclusions of this study is that while they were able to find some meaningful subgroups of individuals, we might be missing people entirely by exclusively relying on a single kind of data. They also looked at whether or not the deaths by accidental deaths clustered in the same way and in the same places as the deaths by suicide, which they weren't. So they were able to not only validate the model within the sample that they had, but they were able to show that it was specific to deaths by suicide. So far I've talked about heterogeneity in suicidal thoughts and behaviors and how clinical and environmental information might yield information relating to subgroups of people at risk for suicidal thoughts and behaviors. But what about the biology? Well, unfortunately, no one has yet published on that. But there are some studies that are in progress. This one study in particular is looking at two different subgroups of people experiencing suicidal ideation and are at an increased risk for attempt. This first subgroup is a group of people with potentially childhood adversity. They have changes in their stress responses, and they're experiencing poor cognitive control or emotion regulation, and they're experiencing what we would call reactive aggression, which is to act aggressively or angry in response to a stimulus. This subgroup, they hypothesize experiencing something they call variable suicidal ideation. So it's ideation that changes across time. It's not consistent or persistent. And they hypothesize that this subgroup will lead to impulsive suicide attempts. The second subgroup is much like the depressive subgroup that I've talked about before, where they have low aggression and potentially good cognitive control, but they are experiencing a depressive episode. We may experience atypical serotonin function, which leads to sustained suicidal ideation. So it's persistent, constant suicidal ideation, which they hypothesize leads to planned lethal suicide attempts. And in this study, what they're planning on doing is they are going to be trying to validate these two subgroups of suicidality using a variety of biological and clinical measures. So they're recruiting 100 people, they're tracking them for 2 years. They're going to do tests related to stress, cognitive function, and aggression, as well as fMRI paradigms, PET imaging, which will look at serotonin function, and something called ecological momentary assessment, which is when notifications are pushed to your smartphone to prompt you to rate your mood. And they'll be doing this for a week at multiple time points over the 2-year period. And this study is currently underway. So unfortunately, there aren't any yet studies validating these two subgroups of individuals, so stay tuned. Now, my area of subtyping is predominantly in depression. And in depression, as I've told you, it is also clinically quite heterogeneous for some of the same reasons that suicidality is heterogeneous. There's different environmental factors, medical and clinical comorbidities, and biological factors that can contribute to depression. And we were able to leverage a very large sample of individuals with depression who were all scanned using something called resting state fMRI, which is a way of scanning the brain with MRI, but instead of having them complete a task in the scanner, we just tell them not to fall asleep and let their minds wander for about 10 minutes. We also collected scales related to their depression severity, and notably, this sample had a fairly uniform level of suicidality across the board, such that this is the Hamilton rating scale for depression item assessing suicide risk. It goes from 0 to 4. So we didn't have anybody with a 4. They hadn't attempted recently, which is what that 4 represents. But we did have quite a large group of individuals who were actively suicidal with suicidal intent or a plan. And what we did is we used a technique called canonical correlations analysis, which is a data-driven technique of not just defining, it doesn't define latent classes, as I talked about with latent class analysis, but rather latent dimensions. And what that just means is it's trying to look for patterns in our clinical symptoms and patterns in our brain imaging that are related to each other. And we were able to find a number of different of those latent dimensions. The first was a latent dimension related to mood and somatic symptoms. So low mood and feelings of pain and fatigue and feeling weighed down, heaviness in the limbs, things like that. And this particular constellation of symptoms was related to specific patterns in the brain, specifically areas of the subcortical of the subcortex, so areas of basal ganglia and thalamus, which are responsible for coordinating quite broad circuits in the brain related to all from mood and anxiety to cognitive control. So these large, widespread circuits implicated in cognition. The other dimension that we saw was related specifically to anhedonia, which is the inability to experience pleasure or a disinterest in things you typically enjoy. And in this case, we found that it was related not just to areas of the brain that we know are involved with reward processing, but also these areas here, dorsolateral prefrontal cortex and dorsal anterior cingulate, which are responsible for orienting us to relevant information in order to make an appropriate decision. And so with these two latent dimensions, we were able to subgroup individuals into four subgroups of depression. So this is what we would call a dendrogram. Each row here is a person's scores on these two dimensions. The closer they are here, the more similar they are. And you can see the four subgroups here. And these four subgroups did differ on a number of different clinical symptoms, but specifically, they did differ in terms of their suicidal ideation severity, such that subgroup number one here had the lowest rates of suicidal ideation, and subgroup number three had the highest. Interestingly, they also had the highest levels of anhedonia as well, but not mood or somatic symptoms. These subgroups were also associated with response to different treatments. And in this case, all of the patients in these studies were treated with some form of non-invasive brain stimulation called transcranial magnetic stimulation. They were treated with a variety of different ways of doing it, different places in the brain to stimulate. But no matter which way you looked at it, the group that had the highest levels of suicidal ideation had the lowest response rates to transcranial magnetic stimulation, so subgroup here. Only 20% of the group got better compared to 40% in the two best subgroups. We also tested this in a new group of a sample of patients experiencing depression. We were also able to show that this was also the case for people who received an SSRI, which is a selective serotonin reuptake inhibitor called escitalopram, which is a commonly used antidepressant. It's one of the first that you might receive. Now, I've only talked so far about cross-sectional studies. Can biology tell us who is at the greatest risk for suicidal thoughts or behaviors in the future? So far, no one has yet done that, looking at subtypes using biology in that way. But there is a preprint that I wanted to talk about. This is from a large sample of kids, about 12,000 kids from ABCD, which is, I think, the Adolescent Brain Childhood Development Study, if I remember the acronym correctly. And what they did was, this is a large open data set of kids who are being tracked every couple of years. So they're recruited, I believe, at 7 or 8 years old, maybe a little bit older. And every 2 years, they're brought back in and they scan them again. They do clinical assessments again. They look at their function, all those things. And from the very first time point for everybody, they identified 1,600 individuals, 1,600 kids who were experiencing suicidal ideation. And they used those 1,600 kids and they picked out some features that we knew were related to suicide risk, such as distress, decision making, cognitive impairments, and social perceptions, in order to define subgroups of patients experiencing suicidal ideation. They were able to identify 5 subgroups in this case, and using the healthy sample from the same ABC study, they were able to identify differences in brain structure and function, genetic risk for psychiatric disorders, looking at cognitive and environmental risk factors. And because these kids are tracked every couple of years, they could ask the question whether or not their subgroups predicted risk 2 years later. So these 5 subgroups differed on a number of different measures. As I said, they looked at cognitive ability, psychiatric symptoms, environmental risk, and then neuroanatomical or genetic factors. And interestingly, the 2 subgroups that experienced stable suicidal ideation were the ones that were experiencing both increases in internalizing and externalizing behaviors. They had difficulties with living conditions. Sleep was a consistent concern. And they also saw changes in brain volume. One group had an increased risk for genes related to ADHD. Subgroup 1 was more depression related, they thought, and subtype 2 was related more to ADHD related phenotype. And what was really interesting was these 2 subgroups saw higher levels of suicidal ideation 2 years later related than the other 3 groups that they found. So subgroup 3 was related to impulsivity and had some differences in terms of brain structure. Subtype 4 was related to psychosis and impulsivity. And subgroup 5 was related to high socioeconomic status, high family conflict. And you can see here these were all treated with different rates of different interventions, from antidepressant agents all the way to CBT and antipsychotic agents. But it's worth noting again that the 2 subgroups related to depression and ADHD had the highest rates of suicidal ideation even 2 years later. So I've shown you some different ways of researchers, including myself, have leveraged clinical factors, environmental factors, and biological factors to try and understand a heterogeneous group like suicidality. But there are some challenges that remain, and I'd like to just walk you through a few of them as we kind of trudge through this area of work and trying to leverage not just existing data sets, but also like ABCD, but also generating new ones. So the first question is, what are we predicting? So what is the goal of subtyping in the context of suicidality? Should we be identifying subtypes of ideation, attempt behavior, or death by suicide? The literature, including the broader literature related to the biology of suicidal thoughts and behaviors, uses very inconsistent definitions, different scales, and different assessments. The other thing that is different across many studies is what the control group is. Is it, in the case of death by suicide, accidental deaths? Is it clinical cases without any suicidal ideation? Is it healthy individuals? Studies consistently differ. And of course, different dependent variable, or what we're trying to predict here, or what we're trying to generate in terms of subtypes of suicidality, our models are going to vary. The death by suicide model is going to be different than the ideation model, for example. The next problem is that we need large data. So the bigger the data set, the better the model is going to be stable and generalized to new data. And this is just An example, you don't need to read the table at all, but all you need to see here are these two columns here, where 0 is that the model is not stable, 1 is perfectly stable across many, many subsamples. And as the sample size gets bigger, the data gets more stable, the model gets more stable. This median relates to performance. Again, higher is better. And as our sample size goes up, the model is performing better to new data. So one way we leverage or try to generate large data sets is by leveraging existing data sets and trying to put them together. But that's not trivial. Data sets can vary by study design, eligibility criteria, so who they let into the study. As I said before, they leverage different scales and assessments. Some studies may collect blood, where others will collect MRI. And then the data availability can also differ. So some data is available in its raw form. Everybody has different ways of processing their data, or different genetic assays and all these different things. And so excuse me, how we handle that isn't trivial. So we can either collect the data in the same way ahead of time, or we can use statistics to try and account for these differences as best we can, in order to put two data sets together. And just a quick example of this is we were looking at subtypes of SSRI response with one data set of 130 individuals. And ideally, a model is not sensitive to differences in how we handle our data or the study designs that we can use in our clinical trials. And we were able to show this discovery data set, or the data we used to train our model, was in an what we call open label data set. So there's no placebo control, no other treatments being offered. They just got an SSRI. Whereas in our validation data set, they were randomly assigned to one of many treatments. And yet we were, and different pre-processing of our neuroimaging, for example, and we were still able to show that our subtypes were valid in this new data set, indicating that our model wasn't sensitive to idiosyncrasies in how the data was collected or processed. The other big problem about leveraging existing, say, depression data sets, for example, is most people don't recruit suicidal people in clinical trials. And a lot of these clinical trials leverage like drug company and drug trial eligibility criteria in order to recruit participants into biomarker studies. So these are three examples of three fairly large depression trials, all of which were the purpose of which were to assess biological markers predicting outcomes to different depression medications. And again, these are different items from different scales that are measuring suicide risk or suicidal ideation severity. And they skew to 0, meaning that an overwhelming majority of these patients are not suicidal at all. And indeed, only across all of these three studies, only 17% of the depression sample are actively suicidal, and only 2% had a specific intent or plan, meaning that we're selecting out these patients and not including them in our research. Meaning that if we were to apply these biomarkers or biological subgroups to a highly suicidal sample, they may not generalize well. And so more research is needed, and inclusive research of this population in order to develop valid biologically based or even clinically based subgrouping models for suicidality and depression. The other thing that is worth considering is, what are we collecting in our patients and our research participants? Data can be, there's always this trade-off between lots of data. We want to collect as much and as varied data as we can in an individual, but that's only so tolerable. So is it really feasible to collect everything under the sun? Do we have the budget for that? Probably not. MRI is very expensive, for example. It's $600 an hour. And so we can use different, even if we do have a very rich data set, what we use in our model is also not trivial. And so different models will use different ways. So these theoretical and clinical models are doing feature selection, where they decide which features are going to be put in the model. But there are also these data-driven ways of looking at what features should go in our model. So feature extraction, which is also called dimensionality reduction, is data-driven techniques of basically reducing the complexity of what goes into our model, whereas feature selection is a step in which we decide which features go in. Lastly, many of these studies only collect biological measures cross-sectionally. Ideally, especially in the context of suicidal thoughts and behaviors, longitudinal studies are likely needed. So cross-sectional meaning we only collect data from people one point at a time. Longitudinal is when we repeat assessments at multiple time points. So far, what I've shown and what has been done is that only the biological measures are being acquired once in order to look at subgroups, which might not be sufficient. So how can we assess things longitudinally? Well, one is using ecological momentary assessment, which I talked about before. In this example, which is really cool, they looked at the frequency and severity of suicidal ideation and found three groups of patients experiencing suicidal ideation, severe and varied group, with high levels of ideation, something in the middle, although they experienced suicidal ideation at the same rate, they were not as severe, and then a third group with low levels of ideation. We can use things like actigraphy. So these are like smartwatches or other wearables that can track activity. This just example, no, it's not yet really been used to define subgroups of patients experiencing suicidal ideation, for example, but has been shown to identify people at risk for relapse in depression, finding that differences in activity and variability in activity across time is related to risk for relapse. The last study I'll mention is leveraging longitudinal resting data from MRI. And again, this has not yet been done in suicide research, but it has been done in depression, where Chuck and Lynch and colleagues recruited 6 individuals, and they invited these patients to come and get MRIs about weekly, every 2 weeks or so, for up to 2 years. And they tracked their clinical symptoms across time as well at every visit. And so this is the anhedonia of a single person. SIMD4 is their ID, across 62 visits across 18 months or a year and a half. And you can see their endorsement of anhedonia as a symptom fluctuates considerably across time. They were able to locate a particular area of the brain and how it connected to other areas of the brain that was able to predict their severity of anhedonia, specifically the nucleus accumbens, which is an area related specifically to reward processing, and dopamine, which is one of the neurotransmitters related to reward processing, and its connections with an area of the brain called the anterior cingulate cortex, which is responsible, again, for orienting attention and deciding on appropriate actions. And the way in which these two regions talk to each other decreases as anhedonia gets worse, meaning that we're not taking our reward valuation into account as much when making decisions. And they were able not just to show that their brain connectivity of these two brain structures was related to anhedonia on the day of this person's MRI, but also it predicted future, it predicted like the next visits, anhedonia as well. So they were able to predict at the individual level using brain connectivity how anhedonic this person was going to be. So it's very early days in doing this level of work. It's very expensive, of course, and not feasible to scale entirely, but it is revealing which brain networks and how at the individual level are contributing to changes in mood and transitions in and out of different mood states, which might be particularly valuable in dynamic conditions and symptoms like suicidal ideation. The last thing I'll mention is on utility, which is we need more data to validate all of these different models that we generate. And really, the gold standard is to predict future risk, right? So we're using, what we know about people and the ground truth, whether they responded to treatment, for example, or not, in order to validate these models. But really, the high and gold standard that we higher bar and gold standard that we're striving to is to leverage these models to predict new people's prognosis or risk or to inform treatment selection. And my last two slides before we get into the questions is just two studies that are doing exactly that in the context of depression. One is looking at TMS, that non-invasive treatment, brain stimulation treatment that I mentioned. They're using MRI to subgroup people into subtypes and then assigning people treatment based on their subtype. This study is still undergoing. And then the last is Optimum D, which is using EEG and blood-based markers to assign treatments, either to an SSRI or an SSRI plus an antipsychotic. And so, again, these are both studies that are ongoing, but are integrating algorithms that leverage biological information to try and inform clinical decisions. So with that, I'll just leave you with a few takeaways. I hope from my talk you now understand that suicide and suicidal ideation and behaviors varies across individuals and across time. Subtyping approaches may have the potential to advance our mechanistic understanding of suicide and how biology and environment may interact to generate subgroups of individuals. They may be able to help us with treatment selection or prognosis, or to develop tailored prevention strategies for individuals. Lastly, there are several areas for improvement from integrating retrospective data to generating new data that need to be dealt with as we generate these models and these areas for improvement will impact how our models perform and how they can be used. So yeah, I'll stop there and thank you.
Great. Thank you so much, Katie, for that really comprehensive talk. There's a lot going on. There's a lot of moving parts. Um, I think we have time for a few questions, but maybe I'll start off with one. Is that I know a lot of the research is focused specifically on depression. Do you think that this will hold across different diagnostic categories, like the different subtypes?
Yeah, so it's interesting. So again, that is one way in which many of these subtyping models vary, is some use only or leverage data only from people with depression. Others are using healthy adolescent or healthy adult samples in the context of some of these clinically based or cognitive based subtypes of
Mhm.
suicidality. And the ABC study is looking at suicidal ideation irrespective of comorbid conditions. So your models vary considerably, although many of the biological markers definitely are focused in, within a particular psychiatric condition. But I do think it varies um,
Right.
quite a bit.
Mm.
Yes, I mean, subtyping models generated on one homogeneous, quote unquote, clinical condition may not generalize well to another. And in our original Nature Medicine paper looking at subtypes of depression, our subtypes did generalize well to people with an anxiety disorder, for example, but they didn't for the negative symptoms, say, of schizophrenia,
Right. Right.
indicating, different biological processes. So
Right.
I do think it depends quite a bit.
Right. So, I mean, it sounds like even like clinically there might be some overlap in symptoms across disorders, but biologically there might be some different processes that are happening.
Yeah.
Yeah. Okay. So we have a question from the audience. Said fantastic talk. Given that top-down theoretical models sometimes lack consensus among assessors in practice, how can bottom-up biological approaches like resting state fMRI subtypes that you're working on be best translated into reliable diagnostic tools for clinicians in the front line?
Yeah, no, that's great. Yes, thank you for that. I think that these are all tools in the toolkit, right? I don't think you can fully replace assessor rated impressions of patients or their self-reported symptoms entirely with imaging. But I do think that it can inform the decisions made at the end of the day. I think it's different tools in the toolkit. As I said, I think these models have yet to be fully validated at this point, but and then there's always the issue of scalability, especially in Canada. I mean, an MRI model right now is just not feasible given the limited number of MRIs, for example. But if it's, say, giving somebody an actigraph, like a wearable for a week, then you have a sense of their chronotype, how they sleep, how active they are throughout the day. That might give us a better sense of risk for relapse or something like that than simply giving an MRI. So I think it's a blend of scalability, triaging some of these more expensive or hard to access tools. So where I see MRI going really is like, I think it's most valuable in very treatment resistant populations. For example, in informing, okay, where we should stimulate in the brain, for example, or should we skip TMS for something else, say ketamine. It's a higher risk sample, and so maybe it's something that clinicians can use if people are coming in crisis to help with care. But in the outpatient level, I don't see MRI fitting in there, but maybe proxies related to different imaging measures, say with wearables or other proxies to measure health.
Yeah, and I think that kind of highlights the importance of developing these models, not just biologically, but integrating the behavioral clinical aspects to see what those behavioral clinical proxies actually might
Yeah.
be. Um, so a lot of people are saying this was a wonderful talk. I know that we're just at time, so thank you. Such as really comprehensive, Katie. And I think that, again, a lot of people don't associate biology with suicide risk, but it is part of the story, right? That's kind of the reality of the situation. So it's really exciting the work that you're doing, and excited to see where this goes too. So thank you everyone for participating. Please sign, sorry, not sign, but address fill out the feedback form, please. And our next talk is going to be on Monday, May 11th. Dr. Daphne Korchik is going to be speaking on suicide risk among youth. So looking forward to seeing you all there. And thanks again, Katie. Bye, everyone.